Hi everyone, welcome back to yet another session with the Conceptual OBG. And today I'm going to have yet another OBGYN Nugget. And that OBGYN Nugget is something that you need to understand very clearly because it happens to be an obstetric emergency, something that can make a difference in life and death for a female. I personally, in my experience, in my clinical experience, have seen at least two to three such deaths, and they all have been referred patients to us. And I mean, it is that fatal and it is that quickly fatal. So, the topic for today is going to be postpartum uterine inversion. Postpartum uterine inversion is basically when, in that immediate period after the baby is delivered, and you have that uterus which has inverted out completely. It can be during your vaginal delivery or it can be during the cesarean section. But the point here is that the uterus completely comes out. Now, this is in much contrast to chronic inversions, wherein over a period of time, because of lax pelvic musculature and endopelvic connective fascia, over a period of time, the uterus gradually comes out and gets inverted because that is not an emergency. That is, in fact, something that has to be operated, but आराम से कर सकते हैं once you reduce it, the edema, the topical ulcers and all have been reduced. So chronic inversion is a completely different topic and the management for it is also completely different. Whereas in a patient with postpartum uterine inversion, the management will have to be taken place within minutes. So, first of all, what are the reasons, or what is the biggest reason which leads to postpartum uterine inversion? And the biggest and probably the only reason for it is going to be forceful pulling of the placenta and its cord. So, a lot of times we tend to forget that in active management of third stage of labor, what we say is controlled contraction. Controlled contraction is the word. It is not just removing the placenta somehow. And the point that goes missing is that we have to do it in a way that we call as the modified Credé or Creds maneuver. Now, this is something that we don't find mention often, but we do it in our practice. We probably don't know that it is called modified Creds maneuver. I'll be showing you all a picture, and that picture is actually one wherein if a placenta has been stuck inside, how do I remove it? So in third stage of labor, you can see over here how I'm removing that placenta manually. I've put my hand inside, I'm holding the uterus like this, but even remember, even when you're not removing it manually and you're just giving a traction on the cord, I did not find a great image, so I just use this. You have to hold the uterus like this, or at least you have to keep your fist over here. You have to keep your fist over here and you have to press this area so that the uterus stays in that location while you're delivering the placenta. Now, this happens to be the CREDS or modified CREDS maneuver. Now, the advantage of doing this maneuver is that it helps retain the uterus inside and it does not come down along with your uterus in a way that it gets inverted completely. But then you would ask me, so what? What if it is getting inverted? Can I just not correct it? No, there are major problems. There are a few major problems that can happen. The first one is that whenever you invert it, all the ligaments, and the ligaments that I intend to say are your uterosacral ligaments, your cornual ligaments or your round ligament, or even your cardinal ligament, your uterosacral and cardinal ligaments are in a complex. All these ligaments, they get stretched. So due to the stretching of these ligaments, the patient can have an attack of vagal shock. The patient can go in a state of shock and all the signs of cholinergic signs जो हम कहते हैं, parasympathetic nervous system is going to take over. So the patient is going to suddenly have bradycardia. The patient is going to have hypotension. There can be bronchoconstriction, making it difficult for you to even intubate this female despite dropping SpO2 levels. So all these signs are going to take place immediately. It will lead to a state of vagal shock, and that is something that can be very dangerous. Secondly, the problem that is going to occur is that once inverted, all these sinuses on the endometrium or decidua, whatever you may call it, endometrium, जहां पे placenta was inserted or where the placenta was attached, those are going to be completely opened up on inversion and they are literally going to spurt out all the blood, spurting of blood from those sinuses. सो जब भी ये तुम लोग का यूट्रस ऐसा बाहर आएगा, ये जब सब ऐसे जो आइडियली इन्वोल्यूटिंग यूट्रस के साथ दे शुड हैव बीन शट ऑफ, they will start spurting out blood continuously. And lastly, your myometrium cannot contract. The myometrium is going to be in a state of shock. Myometrial contractions will not happen because you have completely inverted it. The myosin, troponin, जो भी सब है उनका मिलना बहुत difficult होगा, and the contraction is not going to take place, and that is going to lead to atonic PPH. And you have to remember that even after I correct that inversion, I just push back that inversion, the uterus will take some time. It is not going to be an immediate thing. It will take some time for the tone to be achieved. Probably the tone may not even be achieved, so you might have to even do a surgical procedure like uterine compression sutures, burst, अपना ये जो बीलेन suture होता है, not burst, sorry, बीलेन suture और हेमन suture करना पड़ सकता है. Or even if that doesn't work, then you may have to do even a hysterectomy for her for atonic postpartum hemorrhage. And of course, you have to keep on giving her uterotonics continuously. So that atonic PPH is something that can be very dangerous. So what do I do in this scenario? The first thing that I need to understand is whenever there is an inversion, I might have to give her atropine.